It is interesting, if you look at the transition of the talks, we had some fantastic talks on introductions, style and methods of imaging, and then septal defects, and then hypoplastic left heart syndrome. So we're jumping sort of from perhaps more simple things to something that's pretty complex. But actually, if you think about it, there's a genius in this, there is some thought in this progression. Because from the perspective of imaging, when you look at the fetal heart, you look at the septum, right? That strikes you. It's the cross in the middle of the heart, and so it's an important area for attention. And then you count chambers. This is a condition where if you count the chambers, it does not add up to 4. It adds up to 3, or perhaps the 4th looks abnormal in some way. So that's what we're going to talk about. There's a bit of baggage, I think, that also comes along with this term of hypoplastic left heart syndrome, and you'll see what I mean as I get to the therapeutic aspects of this. There's still some controversy about this particular condition and the approach to it. No question that what this audience does, which is you are the first contact, the first entree into the journey for these patients when you count those chambers and you see that they don't add up to 4 and the left side looks small. So I think it is going to be valuable to you as we go through the next couple of slides for you to learn a little bit about the diagnostic aspects as well as a bit about the outcomes, because I do think it is important for this audience to know what the implications are once you detect this particular diagnosis. So the definition of this condition, interestingly, it's not a single condition. And this is important because whenever we talk about genetics, people often ask, okay, what are the genes or what's the genetic backdrop to hypoplastic left heart syndrome? It's not a single condition. It is a categorical diagnosis that's defined as a form of congenital heart disease in which the left-sided structures are inadequate to provide for systemic perfusion. And as Edgar just showed you, there's actually one particular type of condition where there's an unbalanced AV septal defect with the left side being small. That's one subtype of hypoplastic left heart syndrome. So the variety of anatomical variations include the more classic, like mitral atresia, aortic atresia, where the left side of the heart is just not formed at all, to mitral stenosis and aortic atresia or stenosis, where there's perhaps a small left ventricle but clearly inadequate in its capacity to do what you expect it to do, to an unbalanced AV canal or AV septal defect, and other more complex forms, such as where there might be conotruncal anomalies of, say, double atlet right ventricle, where the left side is not formed either. All of these categorically are under the heading of hypoplastic left heart syndrome, with many genetic mechanisms that lead to these different conditions. So an interesting point here, I'm often, as a clinician, asked, okay, who's the oldest patient that you know of with hypoplastic left heart syndrome? This is a report from The Lancet from back in 2015, where they identified a child mummy sitting in this position, found at the top of the Andes, 6,500 years old. This particular mummy now sits in the museum in Germany. And of course, somebody decided to do some CT imaging and scanning of this particular 6-month-old, and they found that this is a child that actually had hypoplastic left heart syndrome. Believe it or not, a very small aorta, aortic atresia, very tiny left ventricle. And obviously, 6,500 years ago, we didn't have fetal echo, we didn't have surgical intervention for any of this. How did this particular child survive? Likely because the structures, fetal structures, such as the ductus arteriosus and the foramen ovale, were reasonably sized and persisted postnatally. And because this particular child was at a very high altitude, the pulmonary vascular resistance did not drop, so the lungs didn't fully develop. So there was just a proper amount of balance for this particular individual to survive for a couple of months of age. Elena showed a case earlier of a child with HLHS as well, where the family discontinued care for what sounds like appropriate reasons and such. I will tell you that we still offer this to some particular patients and families, and it's a word of caution. Not always by stopping the medications and therapy do we always necessarily have a demise. Sometimes we have had some patients survive for weeks or even months with this particular condition. In general, though, it is a lethal condition if not approached and not treated properly. So this is 6,500 years ago. This particular condition has plagued human development for millennia, no doubt. But how do we more commonly see this condition today? It's in the following way. First trimester screening, 13 weeks gestation, fetus referred for a cystic hygroma, and you focus in on the heart. So some of these images are, I think, are real world, so they're not perfect, beautiful images, but at 13 weeks, we were able to tell that there looked like there was a pericardial effusion and looks like a single ventricle, likely HLHS. Put a little bit of color on, looked like there was a little bit of AV valve regurgitation across and into this single inlet. Fast forward, same patient now at 18 weeks, and I think things are more clearly evident that we're dealing with hypoplastic left heart syndrome, counting the chambers. There is a right atrium, there's a left atrium, there's a single pumping chamber here, which is a right ventricle. This is a case of mitral atresia with aortic atresia. And at 18 weeks, we can, in fact, get a much better look at the aortic arch. And so I've labeled the position and such. You can see the candy cane aspect of the arch. You get a little bit of a view of the ductus here. But astutely, if you take a look at the transverse aorta there, you'll notice that there's a red jet there. Let me let that play for a minute so you do appreciate that. The red jet means that there's retrograde flow in the aorta. Blood's heading in the wrong direction. And the reason it's heading in the wrong direction is because there's aortic atresia. There is no blood flow forward. The ductus arteriosus is supporting retrograde flow into the aortic arch. Take that same patient now, family decided to go forward with surgical intervention. This is a photo in the operating room. This is that tiny aorta. Give you a sense of the ratio between the aorta and the pulmonary artery, in this case of aortic atresia, mitral atresia. The entire ascending aorta is nothing more than a common coronary artery. It's carrying retrograde blood down to the coronary circulation, but it's nowhere near anything of what we would expect a normal aortic size and diameter to look like. So another common way in which we detect HLHS, this is a scan of, if you count the chambers, there are 4 chambers, but certainly if you look at the left ventricle, you'll see that it is rounded, it is shorter than what it should be, it is barely contractile. There is a valve leading into it, but that valve barely opens. And here's the atrial septum, which is bowing left to right. And as we heard very well earlier today, the atrial septum should normally bow right to left if you have a normal left ventricle. Put some color on, and you can see the right ventricle filling nicely, but the left ventricle really doesn't fill much at all. But you do see these tiny little specks of blood flow at the apex of the left ventricle, similar to a case that we saw earlier. This is a case of mitral stenosis, left ventricular hypoplasia. This left ventricle is under very high pressure, and there are communications between the cavity of the left ventricle and the coronary circulation. These are referred to as coronary cameral fistulae. The word camera is not a camera, but cameral referring to the Latin term to body cavity. So it's between the cavity and the coronary circulation, so coronary cameral fistulous connections. So there is a left ventricle here, but this is HLHS. It's hypoplastic left heart syndrome under the definition of inadequacy of this left ventricle to provide for systemic perfusion. Now let's look at another case, and this is a fetus at about 19 weeks that presented, and gosh, should you look at this left ventricle, I don't think you would say this is hypoplastic in any way. If anything, this left ventricle looks dilated, it looks enlarged, and in fact it is. It's within a context of aortic stenosis that we're looking at this, but we have a very hypo or nearly non-contractile left ventricle within a context of aortic stenosis, which I'm not showing you here at the moment, but just looking at the 4-chamber view, you can see that that's the case. Put some color flow on, and what do we see? from left to right, LA to RA is this red jet indicating decompression of the left atrium. Here's another look at it from the side. You can see this blood pouring across the foramen ovale, left to right, LA to RA, as if what we're trying to do, what this fetus is trying to do, is to decompress the left-sided structures. And that's exactly what is going on. But yet the LV is enlarged. It's not hypoplastic. Take a look at the arch, and what we see is red flow in the arch, retrograde, a reasonably sized arch. The Doppler confirms that there's retrograde flow in the aortic arch. So left to right shunting, dilated dysfunctional left ventricle, left to right shunting at the atrial level, dilated left ventricle, retrograde flow in the aortic arch. We follow this case forward. Here we are at 33 weeks, same patient. Look at this left ventricle. It's the exact same size it was at that 19-week study. What's happened here is the left ventricle has stopped growing. And this is one pathway to get to inadequacy of the left side and hence HLHS. A lot of enthusiasm and excitement about this. I will tell you, in our own experience in Philadelphia, now close to 1,000 patients with HLHS, this occurs in about 4 to 5% of cases. So it's an extremely small number of all the patients with categorical HLHS, but yet a lot of interest in this because the thinking here is that perhaps if we could get that left ventricle to continue to grow by perhaps opening the aortic valve prenatally, that we might be able to recruit that left ventricle. A lot of controversy still about that, and a lot of work that's been done, still being done to create an effort in that respect, but I'm not going to dive too much into that. Except to say the following, though. The features that I just showed you are important to appreciate. In a normal heart, there is going to be flow at the atrial septum, right to the left, and antegrade flow in the aortic arch. However, within a context of an abnormal left side, if there is left to right shunting at the atrial level and retrograde flow in the arch, those are two features that will predict poor development of the left ventricle and the evolution of HLHS ultimately. Now, I've shown you a couple of cases of HLHS, so let us talk about this particular case. And I think we saw some of this a little bit earlier as well, but I'll present it to you in this way. This is a patient that came to us about 37 weeks, late in gestation, and labeled as HLHS. Family distraught, counseled about the need for stage reconstruction, LV being too small. Yeah, I think the left ventricle is small. I'm not going to say that it's not here. It kind of looks small, but it kind of looks long and skinny and narrow, not like that short and fat left ventricle I showed you earlier in mitral stenosis. And what else do you see here that's really important, really interesting? Well, the aortic arch is somewhat narrowed, so we're seeing this within the context of the aortic arch. But take a look at this here. The arrow is going to point to it there in a moment. Look at the atrial septum. It's bowing right to left, which is the way the atrial septum should normally be bowing. Well, as we just said a moment ago, if this is a small left ventricle and inadequate and HLHS, how could the atrial septum be bowing right to left? Left-sided pressure should be high. This flow should be left to right, decompressing. So, in fact, this is not HLHS because take a look at this newborn echo. There's the left ventricle. Totally normal. Now, we always like to take credit as pediatric cardiologists. We cured HLHS here. Kudos to us. But in fact, we did nothing to this patient. We did absolutely nothing except let pulmonary vascular resistance drop. And so this echo is at about 5-6 days of age. So we let pulmonary vascular resistance drop, put the baby in a little bit of oxygen, and what's happened is the left ventricle has now filled with a normal complement of blood flow. Now, to compare it to the fetal echo, I'm just showing you what the LV looked like there. Turned out there was a coarctation, and that was repaired, and this child ended up with a two-ventricle repair. So not everything that's small necessarily, prenatally, indicates inadequacy. And the key features to look at, in addition to the smallness, are the direction of shunting at the atrial level and the direction of flow in the aortic arch. And another clue here is, if it's small, is it short and fat, or is it long and skinny? If it's long and skinny, and you've got an arch problem, and if the atrial septum is bowing right to left, that left ventricle will predictably be fine at birth. So here's just a list of things, if you do suspect inadequacy of the left side of the heart, of what you should be looking for. You need to characterize the left ventricle, look at the mitral and aortic valves, atrial septum being key. We'll talk a little bit more about that in pulmonary vein Doppler, RV function, presence or absence of tricuspid regurgitation, and MCA and UA Dopplers and overall growth. So besides the hypoplasia, two key additional things to look for when you have HLHS, and that's tricuspid valve function and the nature of the atrial septum. Now, why is tricuspid valve function so key? Because if one is going to undertake a strategy of intervention, you have to utilize the right side of the heart to take over the job of the left. I'm going to show you some of the infant surgery here in a moment, but the viability of the right side has to be present. And unfortunately, in about 5 to 10% of cases, one can have challenges with the tricuspid valve. Here's a case of HLHS with a very dysplastic tricuspid valve and the presence of severe tricuspid regurgitation. When detected prenatally, these are patients in which difficult conversations need to be had about the viability of any strategy of care postnatally, or at the very least, a discussion potentially about the use of a replacement strategy, such as a transplant. Because stage reconstruction often does not work if your right ventricle doesn't work. So the atrial septum. As we said before, we're going to hammer away at this point. Normal left side of the heart, normally shunting right to left at the atrial septum. HLHS, inadequacy of the left side, left atrial pressure rises. Whatever small amount of blood goes into the lung goes to the left atrium. It can't go to the left ventricle because there's no effective left ventricle. So you get left to right shunting at the atrial level. In 95% of cases, that's the situation. You have an open interatrial communication. But in about 5% of cases, you can have HLHS and a restrictive atrial septum, or even an intact atrial septum. This is a big problem. Big problem, and one that should be identified prenatally to properly counsel families and to potentially make a plan if intervention is the path the family wants to take. Why is this a problem? Two reasons. One, when this baby's born, how's the blood going to get out of the lungs to mix so that you can have any degree of oxygenation? It's not. So these babies are going to be very, very blue. And even if you can try and open that atrial septum, unfortunately, what's happened is there's been a rise in left atrial pressure during development of the lungs, and that can damage the vasculature in the lungs. And we actually looked at this back in the late 1990s. I was finishing up my cardiology fellowship at the time, and this was a project because we had, unfortunately, plenty of patients who sadly had succumbed to HLHS and an intact atrial septum, so we had lots of pathology to review. But we looked at pulmonary vein pathology. This is an HLHS with a wide open ASD, normal appearing pulmonary vein. This is an HLHS with an intact atrial septum, where what's happened is because of elevated left atrial pressures and elevated pulmonary vein pressures, that's damaged the pulmonary veins, leading to what we see here as arterialization of the pulmonary veins, a very thickened wall and elastic laminae, and this results in some of the morbidities and mortalities that we see in some of these neonates. How do we pick this up prenatally? Sampling the pulmonary veins is important. So Doppler sampling of the pulmonary veins can be done by dropping your color scale. As we saw earlier, that technique is readily known, and one can sample the pulmonary veins and get a flow pattern as you see here. This is normal. This is an open interatrial communication. Here's a case of an HLHS with an intact atrial septum. You can see the dilated pulmonary veins there. There's the atrial septum that's intact. Left atrium looks to be tense, and top pattern shows you what the open, normal pulmonary vein flow pattern should look like, and this is what the pulmonary vein Doppler looks like if you have a restrictive or an intact atrial septum. Essentially, the blood is sloshing back and forth in the pulmonary vein as the atria and the heart contracts during the phases of the cardiac cycle, so blood's going back and forth, indicating high pressure. So these are the two extremes, normal and a restrictive, and it turns out that there's a spectrum in between. You can quantify the degree of retrograde flow in the pulmonary vein by sampling And there are many studies out there that have looked at that ratio of retrograde flow correlating with left atrial pressure at the degree of restriction to egress from the left atrium. One of the other things that we're now doing as well in many of our patients with HLHS is we're looking at the lung texture and lung characterization using fetal MRI techniques. So here's an example of what the lungs look like in a normal fetus with a normal heart, normal pressure in the left atrium. And here's a patient, fetus, with lungs within a context of an HLHS with an intact atrial septum. And what you see are these, the arrows are pointing to some of these, but they're all over the place. These stria that indicate congestion and lymph congestion in particular, and lymphangiectasia. This is now referred to as the nutmeg lung appearance. And this, when present prenatally, is a sign that these lungs are damaged and may not function properly when we undertake a stage 3 constructive approach. So let me spend the next few minutes here, and I think this is a little bit of cardiology, but I think it's valuable for this audience to hear this as you are the first folks who make this diagnosis of HLHS as to how we approach this in the year 2021. It's a 3-staged operation that involves essentially rerouting the circulation so that if you're born with no left ventricle, we're going to assign the right ventricle to take over the job of delivering blood initially to the body and to the lungs. And then, and that's done in the newborn period, that's known as the Norwood operation. And then in 2 additional operations, one at 6 months and one at 2 to 3 years of age, we undertake the task of rerouting the blood flow to the lungs without the benefit of a pump. So we take the superior vena cava and connect it directly to the lung, and that's done at 4 to 6 months of age. And at about 18 months today, more like in the 2 to 3 year age group, we take the inferior vena cava and direct it to the lungs. That's known as the Fontan operation. So yes, believe it or not, you can get blood flow into the lungs without the benefit of a pump. And that's shocking even every time I say that. Nature intended us to have a pump that pushes that blood into the lung, but it can flow if conditions are appropriate in the lung. And that's why patients with a restrictive or intact atrial septum are not candidates for this strategy, because the lungs are damaged. So lung health is critically important for the success of this type of single ventricle approach. So let me show you a quick little video. This is a little bit dated, but I think it shows you a bit about how we reconstruct things in the stage 1 Norwood. We have a small aorta in the middle there. And we're going to focus in on the aorta that's highlighted there and the pulmonary artery in front of it. And those two are amalgamated into a single vessel using pulmonary homograft tissue. This is cadaveric tissue that's available. In order to allow for blood to come back from the lungs through the pulmonary veins, the foramen ovale that you see there is excised, so we create an open intra-atrial communication. So that's how blood gets from the right ventricle to the body. How do we get blood to the lungs? A couple of ways that can be done. One is by placing a shunt or a tube between the innominate artery and the right pulmonary artery. That's a Gore-Tex tube there. Another way is to actually place a conduit from the right ventricle to the pulmonary artery. That's another technique that's utilized. So this is essentially what I've shown you is the Norwood operation, the stage 1 Norwood operation. Lots and lots of literature on this, and probably about 30 years of evolution of surgical technique that has led us to where we are today, that does provide a pathway for survival for most patients with this particular condition. But what we've been able to do now is to stratify based on particular risk factors. So let me go through that with you, because these are critically important from a fetal perspective. There are cardiac risk factors, 2 of which I mentioned to you, tricuspid regurgitation and an intact atrial septum, and those are readily detectable prenatally. And then the presence of extracardiac or genetic anomalies and prematurity. Also, things that should be able to be identified prenatally. So a good amniocentesis, screening and surveillance, and doing everything we can to avoid prematurity. So this is all leading up to trying to reduce these risk factors as we present our patients for intervention. So this is some work we did now over 10 years ago, but it still holds true. We looked at a series of 240 consecutive patients with HLHS diagnosed prenatally and categorized them as either standard risk or high risk being any of the features I just showed you. In blue are our standard risk, in red are the high risk. So 162 of the patients had standard, 78 had high risk, so about a third of patients had these additional risk factors. And here's what happened to them as they went forward in time. 28 patients terminated the pregnancy. Now that's a relatively low number, I will tell you, because this is a selection bias, because most of these patients came to us in Philadelphia because they wanted to partake in the strategy of care that we offer our patients. But nevertheless, even so, 18 patients with standard risk terminated and 10 with high risk. IUFD, fetal loss, occurs in a very small number. So even if you have an inadequate left ventricle, the vast majority of those fetuses are going to make it to term. 3 fetuses had a fetal demise. All 3 had Turner syndrome, interestingly. So Turner syndrome is a risk factor. But otherwise, the absence of a genetic or chromosomal anomaly, those fetuses are going to make it to term. 21 of our patients chose non-intervention, so 5 of the standard risk and 16 that were of the high risk. And yes, for this particular condition, we still, even at our own institution and many others, we still do offer non-intervention for families that are properly counseled and decide not to have surgical intervention at birth. 3 patients had significant tricuspid regurgitation, had a heart transplant. So that gets 139 standard risk, 46 high risk that made it for the Norwood operation. And these are the outcomes for just the stage 1 Norwood. And I think this is striking and important to show you. So 9 out of 10 patients who were standard risk survived the initial operation. And I think that's incredibly important, because what that tells me is that good fetal echo, obstetrical evaluation, an amniocentesis, and getting through and not being premature means I can counsel a family and say there's a 9 out of 10 chance you're going to take your baby home after that initial operation. And if not, then there are additional risk factors that occur. So a quick video of the transition from the shunted state to the Glenn state. And in the Glenn operation at 6 months, we take the superior vena cava and we connect it to the right pulmonary artery. And then at the 2 to 3 year mark, patients come back and the inferior vena cava is disconnected from the right atrium and connected in a number of different ways. But what you'll see here is something called an extracardiac conduit, or a tube graft, that then drains the inferior vena caval flow up to the right pulmonary artery. We saw an image earlier of an increased NT, and I do think that there's so much that happens prenatally that we still don't fully understand, that predicts all of our outcomes, whether we have cardiac disease or not, all the way into adulthood. But here's one really interesting feature that I do want to mention here. This is turned out to be a fetus with HLHS that we had seen at 12 weeks, increased NT. And that patient developed plastic bronchitis, which is a consequence of the Fontan operation and reflects lymphatic insufficiency. So I want to sort of leave you, I've got 2 or 3 more slides to go through, but we'll leave you with this notion, important notion. I think there's still a lot that we don't understand fully about lymphatic development and perhaps some of the markers that we look at prenatally that may predict that some of our patients with heart disease may end up having lymphatic challenges when they get on later in life. And since I gave you a little bit of stage 1 outcome data, let me just show you a little bit of some work that we did back in 2018. Of all comers, patients who present prenatally with a form of single ventricle. I was actually asked this once by a family, which prompted us to have our fellows look at this. How many of those patients, what's the likelihood that if a mom asks you a question, okay, I've got a fetus with single ventricle at 20 weeks, what's the likelihood that my child's going to be alive after we've gone through all the interventions, at least 6 months out after the interventions? And so you can stack up all the studies looking at different operations, but we had the opportunity to look at 500 consecutive patients and do a full longitudinal evaluation. And it turns out that it's about 2/3 will make it from a prenatal diagnosis through Fontan operation for intention to treat, right? So I'm excluding some of the patients who, of course, families decide not to continue the pregnancy. But if you do, in general, for all comers, 2 out of 3 will survive. And I think that's something that our community needs to congratulate itself about, because, again, this is a lethal condition. We're far from done. There's more work to be done, but there is a pathway for survival. And now there's data on 25-year outcome in these patients, and there's about 80 to 90% survival if you have a Fontan operation. What we do know is that morbidity is fairly substantial in this population. They have issues and challenges with a variety of organ systems, and that's keeping many of the pediatric cardiologists quite busy these days. So in conclusion, HLHS is a complex form of heart disease that can be very well characterized before birth. Our understanding of the pathophysiology has led to improved management strategies, and overall outcomes for this have their origins in fetal life, and there's a lot more work, I think, and exploration to be done to better understand that, to improve perhaps some of the long-term outcomes for these patients. Yeah, thanks for your attention.